You walk past one of those high-end med spas, right? And the aesthetic is just, it's incredibly carefully curated.
Oh, absolutely. The white marble, the soft lighting.
Yeah, exactly. The pitcher of cucumber water sitting on that sleek glass counter. You see someone walk in on their lunch break, and I mean, the overarching expectation you have is that they're just going to come out looking, a little more refreshed.
Right, because the industry has done an astonishing job of packaging these procedures. It's designed to feel indistinguishable from getting a haircut or a manicure.
Like a spa day.
Exactly. It's framed as this casual, entirely surface-level tune-up.
But when you actually peel back the marketing and look at the biological reality, like what is literally happening to the cellular structure, the nerves, the tissue, that relaxing spa day looks significantly more like a microscopic war zone.
It really does. The contrast is staggering.
It is. So today, we are tearing into the booming, multi-billion-dollar world of aesthetic and cosmetic procedures. We've got a massive stack of sources today. We're looking at private medical clinic guides, NHS patient leaflets, peer-reviewed studies on laser tissue interactions, and a very recent UK government press release.
Right, because the landscape is changing fast.
Very fast. And our mission for this deep dive is to decode the intense biological realities of that recovery and the rapidly shifting legal landscape trying to contain these incredibly popular treatments.
Yeah, to really grasp why the regulations are changing so drastically and why the recovery process is as intense as it is, we have to, isolate the mechanics. We need to look at what these tools are physically doing to human anatomy.
Okay, let's unpack this, because we hear terms like Botox and lasers thrown around so casually, practically listed like standard skincare
Kind
ingredients.
of like it's a moisturizer.
Yeah, exactly. But let's look at the heavy hitter first. Botulinum toxin. We see it under commercial names like Botox, Dysport, or Xeomin. The common misconception is that it acts like spackle, just filling in a wrinkle.
Yeah, that's a huge myth. It's actually a potent muscle relaxant derived from bacteria. The mechanism is entirely chemical. It blocks acetylcholine at the neuromuscular junction.
Wait, so it's literally stopping the nerve from talking to the muscle?
Precisely. It acts on the snare protein complex inside the nerve terminal. By cleaving those proteins, the toxin essentially prevents the nerve from releasing the neurotransmitter that tells the muscle to contract. The chemical signal just never arrives.
So the muscle is paralyzed.
Right. But the timing of that blockade is what often catches patients off guard. They expect instant gratification, walking out of the clinic wrinkle-free.
But it doesn't work like that, right?
No, not at all. It actually takes 47 days for that chemical process to fully manifest and arrest the muscle movement.
And your body is constantly trying to fight that, right? It's trying to repair that blocked pathway, sprouting new nerve endings, which is why the paralysis fades after, 3 to 4 months?
Exactly. It's a temporary chemical roadblock.
But there is a detail in the NHS patient leaflet regarding the manufacturing of these toxins that genuinely caught me off guard.
Oh, the albumin.
Yes, some specific brands of botulinum toxin are synthesized using components derived from human blood, specifically human albumin.
Which is fascinating from a clinical perspective.
Right, but because of that, there are serious religious considerations. Patients of certain faiths actually have to decline specific brands purely based on how the biological product is stabilized.
It really forces a realization that this isn't just cosmetic magic, It is a profound biological intervention. And that complexity scales up exponentially when we move from chemical paralysis to, thermal destruction.
Which brings us to the carbon dioxide, or CO2 laser.
The big guns.
Literally. So the CO2 laser operates at a wavelength of 10,600 nanometers. At that specific point on the electromagnetic spectrum, the laser entity is highly attracted to water. It basically ignores everything else and just seeks out the water molecules inside your skin cells.
And because human tissue is roughly 70% water, that 10,600 nanometer wavelength is devastatingly effective.
So what actually happens when it hits the skin?
When the laser hits, it transfers massive amounts of optical energy into the water instantly. The water just flashes into steam, it expands rapidly, and causes the targeted tissue to literally explode.
Wow.
Yeah, this is the process of ablation. It completely eradicates the damaged outer layers of the epidermis while driving a highly controlled zone of intense thermal damage down into the deeper dermis.
But that thermal damage is the actual goal, right? The clinical guides make it clear that the heat denatures the existing collagen network, causing the fibers to immediately shrink and tighten the skin.
Exactly. It triggers a massive inflammatory cascade. It forces your immune system to flood the area with fibroblasts to build brand new type I collagen.
So you're intentionally inducing a severe burn to trick the body into rebuilding itself.
That's exactly it. And the precision of that burn is where the technology has really evolved. Traditional CO2 resurfacing ablates the entire surface layer of the skin continuously.
Which works, but the downtime is crazy, right?
Massive downtime.
Ah.
That led to the development of fractional CO2 technology. So instead of a solid beam, the laser is split into a microscopic grid. It drills tiny columns of thermal injury into the skin.
Treating maybe 20 to 70% of the surface area.
Right. And it deliberately leaves untouched islands of perfectly healthy skin in between those vaporized columns.
And those islands are essentially the biological cheat code because the hair follicles and sebaceous glands in those untouched areas are packed with stem cells.
Exactly. They act as a biological reservoir.
So they migrate out to rapidly repopulate and heal the vaporized columns, cutting down the recovery time. But regardless of the method, instantly flashing the water in your cells into gas sounds agonizing.
Oh, it is. Pain management dictates the entire clinical setup. Beyond just aggressive topical anesthetics, operators rely heavily on devices like the Zimmer Cryo 6 or Cryo 7.
Which are basically industrial coolers, right?
Way more advanced than just a fan. They are dedicated thermodynamic systems that blast a continuous stream of sub-zero, chilled air directly onto the treatment site during the laser firing.
So it's numbing the skin.
It numbs it, but more importantly, it constantly extracts bulk heat from the tissue. That prevents the surrounding, non-targeted areas from suffering unwanted thermal necrosis.
Okay, so if I'm visualizing the core difference here, Botox is essentially pausing the video so the screen doesn't crease. But the CO2 laser is like taking a microscopic sandblaster to the TV screen itself, right?
Yeah.
Destroying the surface to force the factory to build a brand new one.
That's a perfect analogy. The distinction between arresting movement and aggressively destroying tissue to force regeneration is fundamental. One manages the mechanics of a wrinkle, the other reconstructs the canvas itself.
But the reality of modern aesthetics is that patients rarely settle for just one mechanism. They stack them. They want the muscle relaxed, the surface rebuilt, and volume added back in with dermal fillers.
Right, the whole package.
So what happens when a patient decides to throw all of these interventions into the same anatomical space? The human face essentially becomes a complex chemical and thermal battleground.
And the clinical community recognized that exact risk, which led researchers at the University of Texas Southwestern Medical Center to run a highly specific study back in 2008. They needed to understand the thermodynamic interaction between cross-linked hyaluronic acid fillers, so brands like Rusty Lane or Juvederm, and aggressive cosmetic lasers.
Okay, I have to push back on this experimental design. I get that we need an animal model, but to test this, they injected expensive lip fillers into the abdomens of Yorkshire pigs and shot them with lasers. Does pig skin really translate to a human face?
I know it sounds wild, but physiologically, it is the most accurate surrogate available. Porcine skin mirrors human skin remarkably well. Epidermal thickness, the depth of the hair follicles, the behavior of the subcutaneous fat layer, it's all very similar.
Oh, wow. I had no idea.
Yeah, so it provides a reliable medium to observe how deeply laser energy penetrates. The researchers injected the fillers, let them integrate for 2 weeks, and then targeted those exact sites with 7 different types of cosmetic lasers. They wanted to see if the heat would physically melt the filler.
And the results split cleanly based on the physics of the lasers, right? The superficial lasers, the ones that target redness or superficial pigment, bounced off or didn't go deep enough. The filler remained completely stable.
Correct. But the deep ablative lasers, specifically the fractional erbium and the deep FXCO2, caused obvious, visible damage to the filler sitting beneath the dermis.
Because the thermal columns drilled deep enough to physically break the chemical bonds of the hyaluronic acid?
Exactly. So if a patient invests significant money into precise facial contouring with filler, and then immediately follows it with deep ablative resurfacing, they are actively melting their investment.
That is wild.
It is. And this biological interaction is why expert providers, like the Castle Dermatology Institute from our sources, enforce a rigid procedural hierarchy. The rule is absolute. You do the CO2 laser first.
Let the skin heal, resolve the inflammation, build the collagen.
Yes. And only then do you introduce the dermal filler to refine the volume. The sequence dictates the survival of the product.
This intense focus on the dermis naturally leads to assumptions about how our underlying biology influences recovery. For decades, there was a prevailing clinical theory that hormones, specifically estrogen, dictated how fast and how well a patient recovered from these massive thermal traumas.
Right, because estrogen is widely recognized as a promoter of wound healing and collagen synthesis.
Which drove that fascinating 2003 Stanford study. Researchers evaluated women undergoing full-face CO2 and erbium laser resurfacing to see if exogenous estrogen-like HRT or oral contraceptives provided a biological advantage. Did they heal faster than women not on hormones?
And the findings completely upended conventional wisdom. There was absolutely no statistical advantage.
Not at all.
None. The postoperative complications, the speed at which the skin re-epithelialized, the duration of the intense redness, it was identical across the board. Premenopausal women with naturally high estrogen and postmenopausal women on HRT healed at the exact same grueling pace as those without.
So the body's emergency repair mechanisms basically max out. The timeline for that repair cannot be significantly cheated by baseline hormones.
Exactly. When you introduce a thermal trauma of that magnitude, the localized inflammatory response completely overrides any subtle systemic advantages.
And we keep using the word grueling to describe this timeline because looking at the comprehensive post-care guide from Aesthetics, what happens when the patient actually walks out of the clinic?
It's intense.
The recovery happens in 4 distinct punishing phases that absolutely shatter the illusion of a spa day.
Yeah, phase 1 is day 0 and 1, the immediate physiological aftermath. The skin barrier has been violently removed. Visually, it resembles a severe weeping sunburn. Patients experience petechiae, which is pinpoint bleeding from the deepest laser channels.
And because the outer layer of skin is gone, it can't retain its own moisture, right?
Leading to massive transepidermal water loss. The face actively weeps a clear or yellow serous fluid as the inflammatory response floods the area.
The clinic guides literally refer to this as the ooze phase. And the most counterintuitive part is the strict no-wash protocol. For the first 48 hours, water cannot touch the face.
It sounds crazy, but it's crucial.
Patients only gently pat the skin with sterile saline, and they have to keep the whole area heavily occluded, essentially shellacked in plain Vaseline or Aquaphor. You have to manually replace the missing skin barrier with petroleum jelly so the raw tissue underneath doesn't dry out and die.
Because if that raw tissue desiccates, it leads to cellular necrosis and permanent scarring. Then, moving into days 2 and 3, the patient hits peak swelling. This is clinically the bronzing phase. The microscopic columns of tissue that the laser destroyed begin to oxidize.
So they turn dark brown.
Yes, and they feel incredibly rough. It creates a sensation of extreme tightness across the entire face.
Then comes days 4 to 7, known as the Great Peeling. As the nerve endings start regenerating, it triggers intense itching. The oxidized dead skin starts separating from the fragile baby pink new skin underneath, sloughing off in heavy sheets.
And the clinical warnings here are terrifyingly strict. Patients must never, under any circumstances, force the peeling. Pulling off a flake of skin before the basal layer is stable will rip the new tissue and guarantee a scar.
To manage the profound risk of bacterial infection during this phase, clinics implement a very specific chemical control. Patients use diluted white vinegar soaks, just a simple mix of a tablespoon of acetic acid to a cup of sterile water patted onto the tissue.
I know it sounds medieval putting vinegar on an open burn.
It really does.
But the mechanism is purely about pH. By slightly lowering the pH of the healing skin, it creates a hostile acidic environment that prevents opportunistic bacteria, like staph or Pseudomonas, from taking hold in the weeping tissue.
Wow. And then finally, past week 2, the patient enters the pinking fade. The physical sloughing stops, leaving the skin intact but intensely pink, highly reactive, and profoundly hypersensitive to any environmental stimuli.
And this extreme hypersensitivity is exactly where patients often inflict the most damage on themselves. There is this deep-seated consumer instinct that when skin is compromised, expensive natural products will accelerate the healing.
Oh, totally. People want to apply organic botanical serums or lavender essential oils.
Which is a biological trap. The experts emphatically tear down the natural's better myth here. When your stratum corneum is vaporized, your immune system is entirely exposed. Natural botanical extracts are structurally incredibly complex, packed with volatile compounds.
So the immune system freaks out.
Yes. Applying tea tree or lavender oil to ablated tissue almost guarantees a severe contact dermatitis. The immune system flags the natural ingredients as hostile invaders. In post-laser recovery, Absolute simplicity, sterile saline, and inert petroleum jelly is the only way the tissue survives.
Beyond the risk of contact dermatitis, there is a fundamental physiological barrier regarding who can safely undergo this thermal trauma in the first place, right? The risk profile is entirely dependent on the Fitzpatrick scale.
Yes, which is the dermatological classification of skin tone and its reactivity to ultraviolet light.
Right, it runs from type I, very fair skin that always burns, up to type 6, which is deeply pigmented skin that rarely burns. And the clinical literature states unequivocally that for darker skin types, Fitzpatrick the Fifth through VI aggressive CO2 laser resurfacing carries an immense risk of permanent disfigurement.
The danger lies entirely within the melanocytes, the cells that produce melanin. In darker Fitzpatrick types, these melanocytes are highly active and incredibly reactive to stress. When they are subjected to the sudden thermal trauma of an ablative laser, they panic. They upregulate massively, flooding the surrounding tissue with excess pigment.
Triggering severe post-inflammatory hyperpigmentation. So instead of smooth skin, the patient gets dense, dark patches that can last for years or become permanent.
Exactly. To mitigate this, practitioners have to alter the cellular environment before the laser ever fires. The protocol demands 4 to 6 weeks of mandatory pre-treatment with topical hydroquinone.
Which it chemically inhibits tyrosinase, the enzyme the melanocytes need to make melanin.
Right. You essentially have to shut down the cellular pigment factories for a month before you introduce the trauma.
When you lay out the reality of this biology, the pinpoint bleeding, the water loss, the vinegar soaks, chemically suppressing enzymes, it becomes glaringly obvious that these are profound medical interventions demanding sterile clinics.
They absolutely are.
Yet we see them being aggressively marketed and performed in unsterile pop-up clinics or high-street salons. That massive disconnect is precisely why the regulatory landscape in the UK is about to experience a seismic disruption.
The sheer scale of the market makes it a nightmare to regulate. A recent UK government press release values the domestic cosmetics industry at a staggering $30.4 billion. But due to lack of oversight, the government explicitly describes it as a Wild West.
So the government is stepping in with a sweeping crackdown slated for August 2025. They are legally drawing a hard line in the sand. High-risk procedures are being heavily restricted. Like the legislation specifically targets non-surgical Brazilian butt lifts.
Where operators inject massive volumes of dermal filler deep into the gluteal tissue.
Right. And because of the proximity to major blood vessels, an accidental intravascular injection can cause tissue necrosis or even pulmonary embolism. Moving forward, these will be strictly legally confined to qualified healthcare professionals operating within facilities inspected by the Care Quality Commission, the CQC.
They're also dismantling the regulatory gray area for what they deem lower-risk injectables, like Botox and fillers. Practitioners will be forced into a rigorous local licensing framework. They'll have to prove infection control, anatomical training, and hold comprehensive insurance.
And to combat the normalization in younger demographics, the legislation introduces sweeping bans prohibiting anyone under 18 from accessing high-risk cosmetic treatments without medical authorization.
Which is a huge step.
It is. And this massive legislative shift highlights a fascinating paradox. The consumer market has normalized altering the face and body as a retail experience, but the government, and specifically the NHS, views these exact same tools through a rigid lens of clinical necessity. Looking at the policy frameworks from NHS Birmingham and Solihull, they will absolutely not fund Botox for facial aging, no chemical peels for sun damage, and definitely no cosmetic liposuction.
The clinical threshold for NHS intervention is remarkably high, even when a procedure has functional benefits. Take hyperhidrosis, for example.
The condition of profound, excessive sweating, typically of the palms or soles of the feet.
Exactly. Botox is incredibly effective at halting that sweat production by blocking the nerve signals. Yet the NHS will not routinely commission it for hands and feet.
I found that detail genuinely surprising. If it works perfectly to solve a medical issue, why withhold the funding?
It comes down to the physiological collateral damage. The palms and soles are incredibly dense with nerve endings, making the multiple injections required excruciatingly painful.
Ouch.
And more importantly, blocking acetylcholine in those specific areas frequently causes temporary, localized muscle weakness. The clinical boards determined that intentionally inducing hand weakness and significant pain just to manage sweat violates their risk-to-benefit ratio.
But the NHS isn't entirely opposed to utilizing aesthetic tools for medical reconstruction, provided the evidence holds up, like with liposuction for lymphedema.
Right. Lymphedema is the mechanical failure of the lymphatic system, resulting in massive fluid and tissue buildup. When conservative therapies fail, They can authorize liposuction. The objective is not aesthetic contouring, it is the physical surgical evacuation of the stagnant fluid to restore mobility.
But here is where the clinical logic gets slightly confusing. They utilize liposuction to physically remove mass and lymphedema, but the policy explicitly states they will not commission liposuction for a functionally similar sounding condition called lipoedema.
Which is characterized by the painful, abnormal accumulation of fat cells that resists dietary intervention.
Exactly. Why does the NHS view removing tissue in lymphedema as a medical necessity, but view removing tissue in lipoedema as essentially an unproven cosmetic request?
The distinction rests entirely on the burden of robust clinical proof. With lymphedema, decades of surgical data prove it offers sustained medical relief. With lipoedema, the NHS argues that the underlying cellular pathology is still poorly understood. There is a lack of long-term evidence proving liposuction offers a permanent functional cure rather than just a temporary aesthetic reduction.
So it constantly circles back to that fiercely guarded boundary between vital medicine and elective aesthetics. We have dug through a massive amount of clinical and regulatory ground today. We started by isolating the microscopic mechanisms, how cleaving snare proteins arrests a muscle, and how the CO2 laser targets cellular water to force neocollagenesis. We analyzed how thermal columns degrade expensive fillers and why your baseline estrogen levels cannot cheat the biological timeline of healing.
We charted the grueling phases of that healing process, from the immediate water loss through the bronzing to the reliance on sterile saline and acidic vinegar soaks to navigate the sloughing phase without triggering bacterial infections.
And we looked at how the sheer scale of this 30.4 billion industry has forced the UK government to implement the 2025 CQC crackdown, trying to drag these intense medical procedures out of unregulated pop-up shops and back into the safety of clinical oversight.
The marketing machinery will always sell the effortlessness of the result, but the biology will always demand a precise, often brutal, physiological toll.
Which leaves us with a necessary, slightly uncomfortable question to consider. As these deeply powerful laser technologies and structural injectables become increasingly democratized, available on every high street, promising flawless skin, we have to evaluate our own shifting baselines. At what point does willingly enduring controlled tissue vaporization, severe localized paralysis, and a genuinely gruesome biological recovery simply become the accepted standard expectation of modern beauty?
It really forces a complete reevaluation of what we are actually signing up for when we book a spa day.
Thanks for joining us on this deep dive. Keep questioning the unseen mechanics of the everyday world. And the next time you happen to walk past that serene, beautifully lit clinic with the cucumber water sitting on the counter, just remember the microscopic war zone unfolding in the treatment room in the back.